Hi, everybody. Welcome to another episode of the ASAP Pathway Podcast. I'm your host today, Dr. Stacy, and I have a friend, a mentor, someone I just admire so much. And I cannot believe I'm just now having her on the podcast. She's been someone I've been talking to for years, Dr. Stasha Gominak. She is a neurologist and has a major, amazing, unique focus in sleep that I have not come across very often. And I think the world needs to hear what she has to say. Hi, Dr. Gominak, Stasha.
Hi,
Welcome.
Stacy. It's great to be here.
Oh my gosh. You just become such a good friend to me over the years, too. So I just want to thank you for that. I said earlier when we hopped on before we started recording that so many of our conversations, we just would jump on a Zoom once a month, every few months, once a quarter. We've just done that for years. And I've just admire you so much and I've learned so much from you. And I wish so many of our conversations were recorded because they organically just go into such unique directions and I learned so much and I've helped so many people and I've made so many connections, even helping other clinicians or other doctors that I've worked with over the years just be open to learning more because of you and your kind, generous lending of your time with me over the years. So thank you for that.
It's my pleasure. And I think, I don't know if you feel comfortable sharing this, but I have restless legs. So I have a sleep disorder.
Hmm.
That is a really important part of being a sleep coach. If you don't know what it's like to have abnormal sleep, you really don't identify with the kind of struggle that's happening in so many people. So I think that's one of the things that both you and taking care of your kids. That's the other
Yes.
thing is moms. One of the things I love about your program is it's moms and kids. And you really have a different focus than the male practitioners, I think.
Yeah. And I will give a shout out to our male practitioner. We got a lot more males jumping in with ASAP Pathway
Good.
than honestly in the beginning. It was, a lot of female practitioners. And what is interesting, even in the sleep realm, I find there's more female practitioners jumping in, just even adult sleep when I got started over 20 years ago. That's where I saw the most female speakers, female leaders in the industry. It was really interesting. I thought, oh, the sleep world has a lot more female leadership interest. I think sleep is, it seems to be a science where you really have to listen, a science where you putting all the pieces together. I think female practitioners tend to, not all, and I'm not saying males don't. I love my male practitioner colleagues, but I do think women tend to be intuitive and they listen. And I think there's a lot of detective work that goes into sleep and it's multifactorial. And um, so I'm with you on that. I do think moms, of course, I have a meme that I always show when I lecture. It says nobody, or no, it says um, a worried mother does better research than the FBI or something like that. Like you get a parent or a mom that's concerned about their kid's health, which was me. And I wasn't getting answers. And you just keep going and you keep searching and you go down rabbit holes till you figure it out. And I still feel like we just hit the tip of the iceberg sometimes, right? With this whole vitamin D, gut microbiome, the endocannabinoid system. Before we go down the rabbit hole with everybody hang on. It's going to get fun. Um I want to introduce people that may not know who you are, Stasha. So, um Dr. Gominak grew up and attended college in California, then moved to Texas for medical school at Baylor College of Medicine, where she received an MD degree in 1983. Her neurology residency was done at the Harvard affiliated Massachusetts General Hospital in Boston. She practiced neurology in the San Francisco Bay Area from 1991 to 2004 and then moved with her husband to Tyler, Texas. Starting in 2004, she began to dedicate more of her practice to the treatment of sleep and sleep disorders. In 2012 and 2016, She published 2 pivotal articles about the global struggle with worsening sleep, the possible causes and solutions related to vitamin D deficiency, and the intestinal microbiome. In 2016, she retired from her office practice to have more time to teach. She currently divides her time between right sleep coaching sessions for individuals and teaching other clinicians the right sleep method of sleep repair, which is how you and I met. And I think um, when you say, "Oh, vitamin D," that's a very simple blanket statement. Vitamin D and the microbiome, and it is anything but simple. That's what I've learned. But it's the bees. It's how the symphony of the bees work together, and it is something you have said to me has stuck with me, and I say it all the time that we do not look at the gut microbiome. We don't give it the basically the emphasis it should have. It is really its own organ, and we are walking around, with organ failure. So many of us, lifestyle changes, environment changes, exposure, to vitamin D, what we're doing with sunscreens. I mean, it has changed us as a species for sure. So I wanted to talk about your journey. 2004, you're like, okay, I want to start teaching. I want to start focusing on helping people. And 2012 and 2016, you are part of these papers. You found something. You had an aha moment in your practice, like, wait a second. I'd love for you to tell people why you just switched from your, neurology, then sleep neurology, because you were dealing with a lot of chronic pain and poor sleep. And
We're just regular neurology cases. So I stumbled into sleep by accident. I was forced there. And I think that's really important. And I also want to mention that all of the things I talk about on my website and all of the lectures begin at a point of observation and listening. So you had a really good point there that listening to your patients and now my clients, because now I'm a sleep coach, is a different way to study sleep than doing things to animals or sleep depriving normals. So I love the basic science of sleep. I love going to the sleep meetings, but they have a very limited focus. And because medicine has become so put in a box over this idea that the only truth can be a controlled, randomized trial. If there are millions of people who are not being helped that have bad problems where we have not gotten answers, then there can't be anything wrong with listening to the complaints of my patients and puzzling over what that might mean. And my role as a physician, as every clinician, is to take the basic science and see if I can apply it in some way to what my patients tell me, and then experiment. That is really what medicine has always been. You
Stasha, that is
try
so
stuff,
important. What you
you
just
try
said.
yeah, you try stuff. All the things that have happened in oral airway treatment over the last 30 years have been, uh-oh, that didn't work. I wonder why. And the thrilling part about talking to dentists is they still think of each person as being unique. They look in the mouth, they recognize that it's a unique mouth, it's a unique person. The idea that this person could have unique deficiency states doesn't even streak them as weird. For medicine, we've been forced down this path that has been, I don't care what you asked me about when you came in, here are the things that insurance will pay for.
Mm.
These are the things I'm supposed to do. We've lost the idea of what our role is supposed to be. So as a coach, I can do exactly what I want, which means listen to what these complaints are and then puzzle over what we could do about it. And then because I'm so focused on biochemistry, I'm usually thinking about it in terms of what does that mean in terms of the neurotransmitters that are going to help us sleep. My view, therefore, of what we're doing with the chemistry in sleep, what is each hour of sleep? What does each block of sleep mean? Is based on observations of what people have told me. And frankly, what your client or your patient tells you is the only truth in the room. The
Mm,
rest of the stuff, we make it up. Humans make up stories, and I make up stories, you make up stories, we all make up stories. If they work for your patients in a consistent way, then they're probably closer to the ultimate truth. The ultimate truth always slips away because then we learn more and we realize, oh, that was only partially correct. So, one of the differences that happened to me in my practice was that what I just said was not what I was trained as a physician. I was trained that this is the truth and this is what you're supposed to do in the room with your patient. And I did that for 30 years. But towards the end of 20 years, the truth had changed. And you realize, oh, wait a minute. 20 years ago, I was told this is the case. For instance, heart disease and atherosclerotic disease, this used to be our dogma about that. Now it's changed. So you have to see it through a slightly different lens. And you also have to understand that medicine has a belief system. I don't care if it's Eastern medicine, Western medicine, dentistry, sleep medicine, we all have a basic belief system. We see the world through a specific lens. That means it's helpful to have more than one practitioner because each one of us has our own view of the world.
mhm.
Many of my clients have a naturopath and their regular doctor and their sleep dentist and me. And we're all seeing things in a slightly different way, which means that we can probably have a better outcome together. And before I go into the story of how I got into it, I want to mention that the reason why you and I are friends is I really feel that sleep always has to be analyzed from a dental sleep anatomic viewpoint. The dentists have all sorts of really important things that they're contributing. I am also a client. I had 4 teeth taken out as a teenager. We now know that is a wrong thing to do for your airway. So I think each person needs both of those views. So when I'm talking about my view of biochemistry, that does not preclude the anatomic airway study. Okay. So I got into sleep accidentally because one of my clients said, all those medicines you've given me for migraine really haven't worked. My husband says I snore like a train and I want a sleep study. And this was back in probably about 2005. And she was a young, healthy female, maybe 32 years old, had a couple of kids, didn't really have any medical problems. She is not the person we were supposed to send for sleep studies. So I sent her for a sleep study. She turns out to have sleep apnea. And the most important part is she was seeing me for headaches. Headache is a very, very difficult field. I was not a specialist per se in that, but I had about half of my practice in headache. And frankly, I was very frustrated by what we're being trained about headache because none of our interventions really work. That's why we're doing all sorts of progressively weirder things about headache. Many of the things that came down during the 20 or 30 years that I was practicing sounded like a good idea and then didn't work. And that's the same with all our medicines. So that means there's a whole population of young, healthy females who shouldn't be sick at all, who have terrible headaches. Why would they have those? And why have I been so unsuccessful? And this gal comes back 3 months later and her headaches are gone. It's not like sleep by itself would interest me because I didn't have anything to do about it. All we're trained to do is give CPAP, but the CPAP helped her. Her headaches went away. And I was like blown away by that. So then I started to do sleep studies in all my headache patients, and I had a lot of them, and they're desperate. The clinician is desperate and they're desperate.
Right.
They'll do anything. They'll go for a sleep study, even if they don't snore. And then soon after that, what happened was most of them did not have sleep apnea. Two important points. One, this gal who started the whole thing had sleep apnea, but she had no drops in oxygen. We've been handed the story that drops in oxygen are the core of why we don't do well with sleep apnea. My patients didn't have any drops in oxygen. That's probably a level of severity in the apnea world. Over the last 20 years now there's upper airway resistance syndrome, and there are all these descriptions that are in dental sleep that are about things that aren't really making the oxygen drop. But then the next question would be, how come they feel so terrible? And how come doing things like CPAP or an oral appliance that change the airway diameter, how can they make them feel better when there's no drops in oxygen if the O2 is the story? Okay. And so right off the bat, I thought, drops in oxygen cause stroke. That's what I do on the weekends. Every weekend that I'm on call, I got people with strokes and I'm seeing them. From a neurology standpoint, drops in oxygen are not the whole story. So then the other question would be, what if we're doing things in these deeper phases of sleep while we're paralyzed? The other second important realization is we get paralyzed during the phases where we're repairing things. That opens a whole new possibility. One, it's really dangerous. Could that mean I would just like occlude my airway and stop breathing and die? Yeah. As far as I'm concerned, that's what sudden infant death syndrome is. They always die while they're sleeping. They don't die while you're feeding them a Cheerio at the
Right.
table. Okay. If I then am focusing on these anatomic truths, okay, and there was just a new article that came out that said these guys just discovered the cells that make us paralyzed. No, they didn't just discover them. They've been discovered since the 60s. The problem is the clinician side of neurology and dentistry has not been forced to deal with the fact that we get paralyzed and to think about what that would imply. If these cells were to turn off during the day and make you paralyzed, what would that look like? It would look
Right.
like cataplexy. You'd fall out of the
Yes.
chair, be conscious, can't move. If you look at it through an anatomic lens, which is not the way sleep has been taught, there are a whole bunch of scientists who are teaching in the anatomic way, but they aren't really getting the same amount of play on the internet. So, one, normal people who shouldn't have anything wrong with their sleep have a lot of problems with their sleep. And when you do sleep studies on them, the most common finding this young, healthy female population with daily headache was they did not have any rapid eye movement sleep. The second half of the night was shot. They'd wake up. Their clinical presentation is I wake up at 3 a.m. and I can't go back to sleep.
Mm.
Or I wake up at 3 a.m. and it takes me an hour to go back to sleep. Or I wake up at 3 a.m. and I just don't feel like I sleep deeply after that. And their clinical presentation is threefold. I have a daily headache, I'm in a bad mood, and I can't remember anything. Now, it's true that I don't have electrodes in their brain. It's true that I'm not doing a supervised sleep study every night. Since this started, we now have trackers. So you can actually record your own amount of RAM. Now, is it perfect? No. But being at a supervised sleep study with 100 electrodes all over your
Yeah,
body is far from perfect also.
absolutely.
So there are certain deductive reasoning thoughts that occur. Well, the first one is, why would they lose their REM sleep? And if they don't stop breathing during REM, so we know that we get the most paralyzed of all in REM, and many of my patients had REM related apnea. They only stopped breathing in REM. And that's why the conversation about paralysis came up. But if they don't have REM related apnea, then what is going on? This is on a neurology basis. This isn't an airway problem. Not being able to go into REM is not about whether or not you can breathe or not.
Correct.
That is based in neurology. That means it's my responsibility. And then the next question would be, what do we know about the brainstem control of sleep? Most of sleep studies have been focused on the cortex, on the brain here. We put electrodes on the surface of the scalp, and then we measure these waves. I think that's very analogous to saying, okay, I have this thing. It's a computer. I don't know anything about it. I'm going to put up these electrical sensors around it, and I'm going to measure the electricity around this computer and try to understand how I can get on the internet with it.
Yeah.
Well, you're not really understanding that there's a digital environment that you have to enter. The brain stem is this very basic area that does hundreds of thousands of things. But one of the most important things it does is it switches us from wake to sleep. That brain stem area, you can't record electrically from it by putting electrodes on the surface. The electrical environment is very, very tiny. There are millions of things happening there. So it'd be kind of like listening to a huge cable that has millions of conversations going through it and trying to take out a single conversation. So most of sleep medicine has been based on what's happening in the cortex. But what's wrong with my patients is happening in the brainstem. It's
Mm.
not happening in the cortex. That means these switches that are very basic, we have very good literature about what's going on in them chemically. So what happened to me over a period of time is I did thousands of sleep studies. The great majority of them had no REM sleep. I started to do sleep studies in everyone. And the creepy thing was everyone who's seeing a neurologist has a sleep disorder by a supervised sleep study. They may say no significant apnea, but
Right.
if you read deeper, you'll see they don't have either the right amount of deep sleep or the right amount of REM sleep, or they may have leg movements or other movements that keep some parts of the body from repairing themselves, because there's a logical jump to, gee, wouldn't it be really dangerous to get paralyzed? What if someone came in and tried to attack me? That means every animal on the planet gets paralyzed. That's very vulnerable.
Yeah.
That tells you things about how we get paralyzed. For how long? Do we wake to a lighter stage of sleep to make sure we can look around, listen, feel what's going on around us, and be sure we're not about to be predated by a bigger animal? Those are not the way that the sleep study experts are looking at sleep. It's the way a clinician who has to piece together an evolutionary picture of why we sleep, instead of doing it by sticking electrodes in the mouse. It's not wrong to do the mouse experiments. It really, really adds to the picture, and you need both. But as a clinician, you need to be able to make these jumps, assumptions, and then try something. Otherwise, you're stuck. I'm going to stop there for a minute and let you ask any questions you might have.
Yeah. Well, it's interesting how, well, I always discuss anatomy and non-anatomical. So both are important. We need to collaborate between um, a lot of different aspects of medicine and dentistry. I always say it's a team effort. You cannot do this by yourself. There's a lot of dentists out there, they get into dental sleep medicine. Usually they start with adults and they start with oral appliance therapy. And we get this airway patent and we see this AHI drop, which is even now coming into question that this algorithm is even uh, right. Does it even matter? Because we see quality of life doesn't necessarily match the AHI. And so that's being challenged. But our jobs right now in the standard of care is let's get that AHI down. Um, but the patient, we get this AHI magical number into this realm of um, acceptable events. They're still miserable. They're still tired. They're still moving. They're still not getting REM. They're still, so it is a neurological issue. Like you said, it's happening during sleep. We're not walking around. Why is it in the sweet spot of sleep? Um, and the brainstem, right? All this important stuff happening in the brainstem that no one's even looking at. No one's even, I love your analogy of let's just get the energy outside of this computer and let's just look at the waves surrounding this computer and see if we can figure things out and not take a deep dive inside the computer. Um, so obviously you started seeing this, patterns in your practice, which I love, love, love that you say this. It's not just existing literature that should be guiding us, right? What guides us is listening to our patients. Each patient is unique. They have their own story. We might need to try different things as clinicians. You know, there is some, like right now in the pediatric realm and the orthodontic interception, um, there is a lot of static happening right now of, well, the literature doesn't support it or the literature isn't. And it's like, come on, we're making the literature. What we do in our
Yeah,
practices, what we see anecdotally, you know, you're experimenting on your patient. Yeah, I am. And we've been doing that since the
that's my
beginning.
job.
It's my job. I am experimenting on my patient. I'm a doctor. I'm not, Joe Blow experimenting on a patient. I have a degree. I'm looking at um, other doctors, what works for other doctors with certain phenotypes. I'm using my mind, I'm using my degree to help the patient in front of me in the chair. So, the way we come up with research is a lot of clinicians are seeing patterns, and we
It
do.
always starts at the clinician observation. Always, new ideas always start there.
Right, and then we start the research. So
Exactly.
it's like, to wait for the research. What are you talking about? We do have to intervene on 3 and 4-year-olds and see, oh my gosh, there is a pattern. I'm using intervention on a 3-year-old. Oh, well, that's ridiculous. Well, it worked. It helped with this and this, maybe not
Yeah.
this. So now what do I do? Anyway, I love the conversation of, we are doctors, we are helping our patients. They are unique stories, each one of them in front of us. And I do love, like, Dr. Anne Marie Morse, I mentioned, from Damn Good Sleep. I mentioned her before we started recording, just to give her a shout out. She's doing amazing things, but she's also looking at patient directed care, like bringing the conversation back, listening to the patient, um, being being physicians again and not guided by what insurance is telling us to do, listening to the patient, doing what that patient needs, reading that sleep study a little differently than maybe everyone's looking for apnea. And then if there's no apnea, the study's normal. No, it's not. They may not have the definition of obstructive sleep apnea, but let's dive in deeper. What's going on with their stages of sleep and their paralysis and the movements, and maybe gut health, and we need to have bigger conversations. And maybe we look into, well, maybe they don't have frank apnea, but maybe they are struggling to breathe and making funny sounds, and they have a vaulted palate, and they need to see a dentist, and they need to see an ENT. So but I wanted to go back to your aha moment. So you have this patient in the chair, and in your office. I say in the chair as a dentist, but in your office, and she's feeling better, and the headaches went away, and you're having these aha moments.
Okay, so here's what happens. 5 years later, we built this idea that these things are happening in the brainstem. And I found the cells that are responsible for getting us paralyzed. And these other cells that are responsible for the clock function. These are all well described in the general scientific literature. And then a patient comes in who's 18, who's a beautiful gal, who's about to go to college. She has headache every day. I give her the medicine that we use for prevention. She comes back. In the meantime, we've done a sleep study, and she has slept for 10 hours. So one of the problems is I've gotten in the habit of saying, how's your sleep? And people who say, it's fine. That doesn't keep me from doing a sleep study. And she said, my sleep is fine. And she sleeps for 10 hours, but she's tired when she wakes up. And her sleep study shows that she has no deep sleep. She tries to enter deep sleep. So every time her brain tries to go into deep sleep, it wakes back up again. So what's recorded on her sleep study is multiple awakenings. She's not awake. She doesn't know any of this is happening. She will be able to tell you, if you will listen to her, that she remembers the entire night. Many of my teenagers and kids, if you know the right questions to ask, are in light sleep all night long.
Hmm.
And you don't realize that humans think it's normal. Normal humans who sleep normally thinks it's normal to lose track of the passage of time. They wake up and 8 hours has gone by and they don't have memories of that. And until somebody said, wait, I don't remember anything that happened last night. And I'm saying, well, doesn't that mean you were asleep? She said, no, you don't understand. She's been sleeping her whole 16 years, but making memories of the whole night. So there are things that the patient can say that tell you they're in light sleep. But until you're doing sleep studies, you won't know to ask them. You don't know what to think about it, because frankly, medicine has said things like, patients don't even know if they're asleep or not. I did a sleep study and they were asleep. Well, they were asleep, but they weren't in the healing phases of sleep. So the feeling of being refreshed, of being ready to go, of, oh, I feel wonderful, is not there. So she has 35 awakenings an hour that are not related to the respiratory state. They are not related to moving her legs. They are unexplained, and she has no deep sleep. And it turns out she has B12 deficiency. Just by accident, I do a B12 level, and it was so profoundly low that even I'm desperate because I just saw her sleep study. I went, this is terrible. She's going to be back here with a stroke in 10 years.
Gosh.
This is a deadly sleep study. So what could be wrong with her? She doesn't have any other medical problems. We don't get confused by, oh, it could be that antidepressant she's on or XYZ. So she's young and otherwise looks perfectly functional. So the idea that her brain might be missing something. So because I'm thinking about the brain stem and I'm thinking about each individual cell and what their responsibilities are in the brain stem, and there are certain clock cells that start firing when they develop in utero, and they fire at the same rate for 95 years. They never get a chance to rest. They can't turn off because your whole clock mechanism is dependent on their firing rate. That means their cellular repair has to happen in between each firing, like 3 cycles per second. So they fire 3 times in a second. And the only time they get to repair their cell and their actual physical ability to do this stuff is in between. So I'm thinking in this really peculiar way that's about cellular biochemistry on a single cell. And she has low B12. So for the first time, I'm thinking, well, maybe that cell doesn't have this thing and it's firing all crazy. And that's why, so I don't really understand what's going on, but the idea that it could be a deficiency state is very attractive because by now I've been doing this stuff with the CPAP and the sleeping pills. That's all I had. It's all anybody has. I didn't have oral appliances at that time. Sleep dentistry, I didn't know about it at all. And they're all failing. So they look good at the beginning, but at year 4, the CPAP wearer is still wearing it, but doesn't feel good. Same thing with the sleeping pills. Same thing with the headache preventatives. They work for maybe 2 years if you're lucky, and then they wear off. And most of those preventative medicines we've used for headache, there's no logic to them. And it turns out they are affecting the firing patterns of cells, and they are about sleep. If you happen to find the right one by accident and this person sleeps better, their headaches do better. So by then, I'm like, okay, let's jump on this bandwagon and do B12 levels. And by accident, one of my patients says, my D level was low. My doctor gave me D and my wrist pain went away. And I just say, throw it in there. We're doing blood tests. This is the first time I've ever done blood tests on headache patients. And so it turns out that the D level is low in everyone. The B12 is lowest in the really, really sickest of the six, the ones that are really feeling terrible. But the D is low in everyone. And it turns out that a couple of guys come in at the end of a 4-month span of doing the Ds, and everyone who's got a sleep study either has headache or some other neurologic problem. So now I've got several hundred D levels, and 2 guys come in and say, hey, this CPAP, you told me it was going to take my headaches away, but it didn't. And I've been wearing it for a whole year. You can ask my wife. I got it on every night. But the last time you were in here, I was in here with you, you gave me that lab slip and you told me my D was low and you asked me to get some vitamin D. And in about 3 weeks of taking it, my sleep got a little better and my headaches went away. Now, 2 guys tell me that within 2 days of each other. And I think this is really weird because everybody's D is low. Why would vitamin D, which I know nothing about, I'm successfully trained away from supplements by medical school. So I go to the basic literature and there are vitamin D receptors all over this part of the brainstem, the sleep switches. All this area that I've been looking at the basic physiology of have vitamin D receptors, which has to mean D is playing a role in our sleep. And the guy that I stumble into has already got this beautiful belief system that's about D is the hormone that runs our ability to actually survive the winter. Duh.
Mm.
You can only make D during the summer if you move away from the equator. So he has this whole prepared way to understand, why would we have a hormone made on our skin from a specific wavelength of light? He's already done all this work. He's been working in it for 30 years. And he has very specific places all over the body, all over the brain. The brain has multiple areas where D is very active. It's a major part of the blood-brain barrier, which then means all the autoimmune diseases of the brain, where the antibodies sneak across into an area where they're not supposed to be,
Right.
are related to D being low. So as soon as I read this, I went, oh, 5 years ago, they talked about that multiple sclerosis is a D deficiency disease, but none of us really caught on to what that means. And still, it is now 14 years later, we still don't have the clinical information we need about how to dose vitamin D. And there's a huge, huge argument going on in vitamin D land around the world and in medicine, to the point that medicine has decided that it's too dangerous, we don't know enough, and we shouldn't do Ds. So the endocrine, there's a group called the Endocrine Society. D is a hormone. That means the only people who understand this deeply are endocrinologists. That's the field that should be taking responsibility and fitting it into many other hormones, because it is one of several that are all interconnected. Every single one of the chemicals we call a hormone affects our behavior. Sex hormones affect our behavior. Thyroid affects our behavior. It tells us to do things. We think we have control over ourselves, but in fact, we are behaving in certain ways that are run by our hormones. It's so obvious with sex hormones, but it's the case with other hormones as well. And D is a hormone that makes you go to sleep in the winter. It's the hibernation hormone. Duh. So that literature was already fully written. Now, the weird part is that this guy, whose name is Walter Stumpf, his colleagues just don't agree with his point of view. They don't look through his lens, even though, like, everybody knows that you either hibernate like a bear if you live in the north, or you migrate towards the equator.
Isn't this why, like, the colleagues just didn't want to even address it as a hormone, and we keep calling it a vitamin?
Yeah, it's so I spend a lot of time when I give these lectures about the history of D, because immediately I was like, wait a minute, this has been there since 1982. This article was reported in 1982. There are people writing in year 2000 about these cells in a basic neurochemistry textbook. That means that the clinicians should have known about this, and we should have been paying attention. Oh, did we move inside, or did we have less UVB light exposure when we use sunscreen? Like, this has been going on for 20 years by then. It starts in the sunscreen starts in the 80s with the computers and the air conditioning. That could have been saving my patients for 20 years now. I've been watching people die of sleep disorders and diseases related to inability to repair my body during sleep. This is a crime. And I start going to meetings, and I start going to a thing called the vitamin D workshop. And I'm blown away by the difference in viewpoint. This is why we started this conversation with, these are belief systems. If you have a certain belief system, you won't see it that way. I happened by accident into Walter Stumpf's belief system first. It made total sense. All sorts of things started to just fall into place. And I would say, wait, all these same women who have headache, they have gallbladder disease and thyroid disease. Both of those are linked to D, directly linked to D. They're also having lots of problem with ovulation. They have polycystic ovarian syndrome, and they're infertile. Walter started writing about that in the mid-1980s, about how infertility would result because there is a blocking system. D, when it's low, says there is no food. Therefore, we shouldn't be fertile. And it affects the male and female fertility. That's in the biochemical literature since the 80s. That means infertility is all about the D level, and all the infertility specialists can read that if they want to. And instead of doing thousands and hundreds of thousands of dollars, all you really need to do is correct your D And unfortunately, you do need to learn about the microbiome, which is the second piece, because what you want for that fetus, once you become pregnant, you must be able to supply all the other building blocks. Those building blocks come from your poop, believe it or not. Your microbiome makes all the other things that your infant is, as they develop, needs to develop normally, mentally and physically. So the first part was this really frustrating, upsetting understanding that medicine is extraordinarily conservative. And the way we teach physicians and the sub-selection process for physicians means that we are very conservative people, and we're not creatives. We don't think out of the box. And we, over the last 40 years, it's become harder and harder and now impossible to actually do anything that's experimental, because I can get sued. Like, if I get sued and the jury doesn't understand that I am talking about the practice of medicine, because the lawyer says, what is the current recommended practice parameters? Well,
Right.
what if those practice parameters haven't done jack
Right.
for this guy? My patient then says, is there anything else we can do? I'm dying here.
Mm-hmm.
So I spent all this time thinking about deeper things. And one of the things I love is the dentists are tinkerers. They're experimental. They're doing little things in the mouth. Okay. They're trained to do things with their hands. They make little models. They put little wires in the mouth. They really are trained in a slightly different way. And they're really focusing on, well, that didn't work. Let's try this. Medicine has been taken out of that possible mindset. So there's a lot that I lecture about because I'm anticipating that the people who hear it are going to go back to their practitioner, who's a smart person, who's well educated, who cares about them. That piece gets lost. All of the physicians that are still in medicine or wouldn't be there if they didn't care. It's too hard. It's really, really hard now because we care. And at the same time, we're like tied. We're the puppets of the insurance company.
Yeah.
That means when they go back and say, I just heard this gal talk about D and sleep, and their doctor says, oh, don't go down that road. The D is dangerous for you. And so the Endocrine Society this year has been asked to make a blanket statement about D. And if you read the details of it, so everybody sends me D stuff. So I get to read all these. If you read through the details, they have addressed every single question that endocrinology should address. And they do a good job of it. And they say these clinical trials that are fixed dose trials are ridiculous. They admit that, they show why. But here's the final recommendation. They say, we do not have enough clinical experience that's been published to say what is the dose. And as soon as we say we recommend a D level of X, whatever it is, the next question from the clinician is, what's the dose I give to arrive at that level? And because we don't know, we're going to recommend that you not do D levels.
Oh,
I mean, that's the final answer.
that's the answer.
Everybody's dying. Everybody's dying because their sleep is bad. D is
Everybody's
well,
sick, gut
yeah,
health issues, poor
but
sleep, but
because we don't know the right thing to say, so there's no room in that comment for, gee, why don't we start doing D levels and recording what dose we give and what the final outcome of the D is. I've got thousands of lay people who are not physicians who are able to do this, and I've given them a workbook. It's not simple. It's not being spoon-fed, which is what we're asking people to do. You really don't need to have the doctor know what the dose is. You need to be able to say, here, you can get your own D level done. And the way you know what your D dose should be is by experimenting and getting the data. Your D dose is unique to you. And
mhm.
every single dose that you do in a month, you should follow with a level. You can explain that to the lay public and say, this is an important part of your ability to have better health and longevity. That is not hard. And that's really what the workbook is about. Now, there's a second part, which is at 2 years of doing D and doing D levels and giving out doses that were very confusing and wondering about why there's so much misinformation, it turns out the most important piece you should hear from this is D is one of the growth factors that the normal human microbiome requires. That means that the fall off the cliff of the microbiome started in the 80s when the D went low. We have been told that the reason why we have the wrong microbiome is because of antibiotics, and that is incorrect. And the reason I say that is for twofold. One, there was a whole 2 generations of people between 1945 and 1985 who took antibiotics because we had them at the end of World War II. I took, antibiotics for strep throat. Irritable bowel syndrome did not show up until the 80s. And there were many other diseases that are still weird names. Non-alcoholic fatty liver, irritable bowel syndrome, fibromyalgia, chronic fatigue, things that weren't reported before that still don't have a believable name, where you go, wait, my belly is mad at me? That's crazy. That means we didn't figure it out. Now, the second reason why I think it's not about antibiotic use is what we were using before humans stole antibiotics from fungus. But keep in mind that we got the first penicillin from a fungus that was making it. And we saw this little fungus growing in a petri dish and went, hey, there's a little clear zone around it. That means, could it be secreting a chemical that kills its competitors? Now we know that trees and plants do the same thing. They work as groups. They put out chemicals that kill their competitors. All of the bacteria, fungus, and virus that live inside us and in our mouth they are all making their own specific antibiotics. Antibiotic means anti-life. Some of them make antiviral, some of them make antifungal, some make antibacterials. Those groups have been over our skin, in our ears, in our nose, in our perineum, all over our body, protecting us. That means we've already been exposed to antibiotics. And in fact, what was protecting us from C. difficile killing us was the antibiotics that were being made that managed the ratios between C. diff, which is supposed to be there, but not in large numbers. So in the background, it is my belief that it was the D going low that meant there was a pandemic of loss of the normal microbiome. And what I didn't expect was, because D is linked, I thought when I gave my patients D that all their IBS would go away, but it didn't. So that was very disappointing. And I also started to see many other complaints that the patient didn't have when they walked in the door. So at the 2-year mark, so we've done really well with D. Everybody's gotten better. This was back in 2009 through 2011. The actual article, the first articles that showed in humans, we give this much D, we watch what the makeup of the poop bacteria is. So we're using poop samples to say how much of this population is this and this and this. And it's taken that long to get good at that. But the very first article that was published about the amount of D that we give and the D level is related to which populations of bacteria are in our poop was published in 2020. So there was this idea that the bacteria are going to change. And in fact, they did a little bit based on that article in 2020. But my patients at 2 years of having perfect D levels in the 60s started to fail in other ways. And those other ways are all related to B5, which is pantothenic acid, which is a completely overlooked B vitamin, and the making of acetylcholine. So the second part of the story is you cannot just give D without bringing back the microbiome, because really bad things will happen to you. And the final piece that really makes a normal human is bringing back that organ of your body, which is the microbiome. The reason why I have a website is that the other people who are supporting the idea that you should bring your microbiome back are using either probiotics or prebiotics, which are not necessarily wrong. They are just not the whole story. Because if you take probiotic means I'm taking bacterial species. If you do not supply the growth factors that those helpful, healthy foursome of phyla. So we knew by the time I stumbled into this second piece that there was a specific foursome of phyla of bacteria that were supposed to be the major species in normal humans. That most of us did not have those in the right ratios anymore. And it turns out that those guys exist as a foursome because they feed each other B vitamins. They feed each other these cofactors that those four need. So there are other articles that have substantiated the idea that there's foursome who are symbiotic because each one needs one of the 8 B vitamins and produces one or two of the B vitamins. So that 8-pack of vitamins, the reason why we have 8 Bs, I mean, it's kind of weird. There's A, and then there's 8 things called B. Like, why? That's weird. They all came from actually growing things in a petri dish, learning about bacteria in a very basic way. And in fact, bacterial growth factor, that name, which means, oh, there's a chemical that must be secreted by this other guy, his friend, that's yellow and got little black dots on top when I grow it in the petri dish. And this little white guy can't really grow unless he's got this little yellow with the black top guy, okay? Then you find out, oh, they're secreting things, they're trading chemicals back and forth. Now we have a huge literature that shows all of these chemicals that we must be able to absorb from our bacteria in order to have a normal human body. And that starts really at conception. So moms have to have a normal microbiome to produce a normal human fetus. That means as we've seen this up of autism, ADHD, all the
Mhm.
things that have become common, it's not just normal. It wasn't normal before. And all other animals out there live outdoors. If they're meant to live outdoors, they live outdoors. We are the only ones, and our pets, that have proceeded to go indoors. And now there's more and more literature that supports the idea that there are multiple wavelengths of energy that we are exposed to when we're out in the sun. And doing vitamin D as a pill is really not duplicating what we do when we're outside. When we're outside, there are other wavelengths of light that probably are designed to make sure that we don't have skin cancer. It turns out there are multiple active forms of D that are made on our skin when we're in the sun that are not made when we take this little pill.
Mm.
So hopefully there'll be more literature coming out about that. Medicine is going to balk at the idea because so far they've they've misinterpreted the ideas of people who are afraid of electromagnetic radiation and said they're wacky. Well, they're not wacky. They're just thinking about the world in a different way. There's lots of literature that electromagnetic radiation is part of our planet.
Well, it is.
That's
We got a big flaming ball that comes up every morning that
yeah.
we are.
And you know,
I
the
mean, if we
northern
didn't need
lights,
it, I mean,
the northern lights are things that you're seeing because a sun flare is changing the energy state of various ions that are in the sky. I mean, you have to look at this through an evolutionary lens that says all of these living things have shown up on this planet spontaneously and they are meant to be in a certain environment. Then it doesn't seem so wacky.
it's back to what you just said about why do we call all these chemicals B vitamins? So, just so I understand, is that why they named them the B vitamins? They were all special chemicals that they realized had a symphony of working with each other.
They
These
came
8
together.
chemicals,
They were discovered together.
they were
I
discovered
think this
together,
is
so
by accident, okay? What happened was they happened to use a yeast bacterial mixture that Mrs. Pasteur had on the counter to make bread. So she puts yeast in water, she lets it sit there. If you've ever made beer or bread, there's a certain set of steps you must do. And if you set the water with the yeast in it at a certain temperature, you'll get certain bacteria that grow. If you put it at a different temperature, other bacteria will grow. If you don't put any yeast in it, you'll get a different set of bacteria. So as you're making the liquid yeast preparation, what you're doing is sitting it on the counter, open to the air, and the bacteria that are in the water and in the air are using the D that's being produced by the yeast. It happens to be D2, a different form of
Right.
D than what we make. But that means that the yeast bacterial mixture that was in this liquid preparation was stolen by Mr. Pasteur, Dr. Pasteur, poured into the Petri. I'm making this up, but this is the history simplified. He pours it into the Petri dish, puts a little agar in it, and starts to look at bacteria. And now from about 1890 to 1910 and 20, physicians are starting to look through microscopes, realize that there are living things, and those petri dishes are the study place. And what happens is when they boil the liquid, they can't get certain bacteria to grow. And then if they don't get it warm enough, they can't get certain bacteria to grow. And that's when this idea, there must be growth factors. And in actual fact, they isolated each one of those things that's now called a B vitamin from that mixture. And nutritional yeast is a preparation that is made exactly the same way and then dried, and then it has B vitamins in it because the bacteria are producing them. And in fact, even today, it turns out that B12 is an extraordinarily complex molecule. It has a boron ion in the middle, and then it has this great big chemical around it. They are still using bacteria to make B12 that we are using as a supplement. It's not made in a chemical formula because the chemical formula turned out to be quite daunting. So they said, well, why do I want to waste my time doing this, that, and the other and wasting all these chemicals? Why don't we just grow the bacteria in a petri dish and then suck the B12 off? I mean, it's free. We're enslaving the bacteria. That's what we're really doing with the bacteria inside us. And that's really what happened at the beginning of all this. The bacteria were here. Those particular foursomes would hang out together, and then they would give these growth factors. And then came multi-celled organisms that had a poop bacteria tube. And we just said, well, I don't need to make all those things because they're making them, and you just absorb them.
It's back to your point of, I mean, this is complex. We still have just touched the tip of the iceberg. Just what you just said about the different types of D, that, we know there's D2, there's D3, but we're taking this D3 form pill. And there have been studies that have looked at, okay, so but again, those studies are probably fixed doses of D. We still have that issue, and nobody's getting creative with the doses per individual. But even still, it's a pill. It's not exactly what we're supposed to be getting. I mean, is it better than nothing if somebody's probably, yeah, but we're not getting the full spectrum of D potentially that
Which
exists.
means we're going to learn what the bad outcome is. Okay. We don't know
Right.
that yet. And one of the really important things about the message here is we have to really look at the supplement industry through a certain lens. And it would be my view that you really want to look at the fact that evolutionarily, the squirrels never took vitamins. We weren't made to take vitamins. Now, that doesn't mean I'm not going to use them, but it means that you have to understand that you're really biohacking. You're changing one thing and you're expecting what we were told, which is vitamins can never hurt you. If you have a good diet, you don't need vitamins. These sort of dogmatic statements are actually incorrect. And maybe when medicine started saying that, which was in the early 80s, everybody had a normal microbiome, and they might have been right. If you have a good diet, you don't need vitamins. That's true. But then there's a practice, which is staying indoors, that results in a hormonal deficiency that then results in losing the microbiome. And there's a huge cascade of terrible chronic illness that comes with that. That means the words vitamin have been taught to us in this very regimented box-like way. And every time that anybody writes a textbook, they try to simplify things so that someone who isn't familiar with the literature can get some basic ideas. But if you simplify it too much, D has never been a nutrient. Yes, it's true that if you eat a female salmon, you'll get estrogen from that female salmon. There will be salmon estrogen in there. Now, does that mean that's your estrogen? No. That salmon also has D3. And if you eat the salmon liver, you'll get even more D3. But was that where you were supposed to get the D?
Right, right.
If an owl that doesn't go out during the day eats a mouse and swallows the whole thing whole, he or she just got a big dose of vitamin D out of the liver of that mouse. Okay. That means each species has a different interaction with this hormone. That also means that we should have an open mind about what's the right thing to do with it. And it's not a nutrient. We've just proven over the last 40 years that the amount of D that we get from living indoors and eating salmon is nowhere near what we should have. Plus, we are losing out on all the healthful effects that we might get from infrared light and other things that come that we're just
Yes.
starting to understand.
It's so interesting. So I know we have our listeners are um, everyday people that may not be in the healthcare profession, and they're looking for healthcare practitioners that are open to this. And there's also clinicians listening to this. I know that may fully, have some understanding of this, or some that it's like, I know there's more and I want to learn more. So I wanted to, and I'm going to put this in the podcast link, how people can find you. Let's say you're a patient, you're a person that wants to further explore this and take your health into your own hands and your children's health in your own hands, because you feel like, you know what, this isn't being addressed by my provider. And now we know why. It's not being discussed in medical school. It's not being discussed in dental school. So your physician is not a bad physician because they do not understand this. It's not being taught. Hopefully, we can raise awareness. The majority of learning, at least for me as a clinician, was after school. So you learn enough to not kill somebody, and then you get out of school and the real learning begins. Um, so, how can people, let's say you're a patient and you want to find a coach, someone that can help you kind of take this journey, learn more about your own D levels, your B levels, um, your children, your family. How can someone that's a patient get help?
My website is called drgominak.com, no dots after the dr. And I just changed my name on the picture so that you know the spelling of Gominak. So I am the only Gominak in the whole world because
And
it's
that
kind
for
of a
those that
made up
aren't
name.
watching, it's Gominak.
Right.
No
And
C
if
in
you
there,
put
everybody.
something similar to that, like Dr. Gomaflagy and vitamin D into the search terms, my site will pop up.
Okay, good.
Okay.
Good.
So I am trying to get my site to pop up more when the word sleep is entered. But at the moment, there are a lot of other competitive uh, mattresses and pillows and etc. that are competing for that. So Dr. Gominak or just vitamin D and my site will come up. I think that entering into this mindset is best through these interviews because there's a whole lot of ideas here. And the first question would be, well, is this Right Sleep program? So I have a program, I have a workbook, we have a Facebook group, we have other lay people who are doing this same program to help you. But the first question would be, I have X, whatever that is, would that help me? And on the website, there's a whole bunch of free literature there. The articles that I publish are also there in the about section. So I would recommend to anyone to look around first. And the first thing you have to say is, does this idea set, does this view of the world make sense within what my physical experience has been with my body? Because my best clients are, well, that happened to me. And oh, that happened too. And that's why that explains why this happened to me after that pregnancy and why I couldn't lose weight after the third pregnancy. So if it resonates with what your life has been like, and you've tried all the routine stuff that everybody's tried already, then this would be the right place for you to go and try things. The program itself is pretty long. It's about a year. It doesn't take a year to feel better, but there's a lot to learn. And my intention is not that your sleep or health should be better like next month and then go out the tubes again, like what I talked about with CPAP and
Right.
sleeping pills, but that you should learn how to use the tools we have available, including diet, exercise, going outside, spirituality. It's not that vitamins are the answer. Vitamins are tools like all these other things. Learn how to do that for the rest of your life.
It's a journey. And just like, even as we age, how much vitamin D, and I mean, it is a journey. It's just like, say you're, 16 years old and you figure out your D level. Well, that's not what you're going to have to do for the rest of your life. I mean, things are changing. We have to understand we're dynamic, be open, and, always just be open and ask more questions. Be in tune to, wait a minute, my sleep's changing. What has changed? Journaling. What's different? Am I drinking alcohol before bed? And what is different? Have I been taking, and that's the other thing is you look at these supplements, and some supplements might have four of the eight Bs or six of the eight Bs, and not all eight Bs, or too much pantothenic acid. I know it's frustrating sometimes. Look, I'm, yes, I'm a dentist, but I'm a mom. I mean, I remember one time I sat in the floor of Walgreens and I was just looking. I took all of the supplements down and I'm looking and I was sending you snapshots. I'm like, is this an okay supplement? I mean, you were just so patient with me, but I mean, it's frustrating. And I'm a dentist. I consider myself a pretty intelligent person, and what I love is you've taken this and you have simplified it as much as it can be. It is complex. So I highly, highly recommend, if you are a mom, a dad, a person, you're just wanting to get yourself healthy, your kids healthy, your parents healthy, um, go to drgominak.com and check it out. It is amazing. It is full of information. I love all these videos that you have. Once you get into the program, and the education is unprecedented, nobody's that I know of is doing this.
No.
And it
Stacey, we
is,
also have a YouTube channel.
oh, okay,
So the
what's
other
that?
thing is that I should insert here is the name of the program is Right Sleep, capitalized on R, capitalized on sleep with no space in between. And that's only because we trademarked it several years ago and it wasn't taken yet to be trademarked. So Right Sleep is the program, but it's also a set of ideas. And if you just type in Right Sleep or Dr. Gominak on YouTube, it'll take you to my website. We've just generated 50 different little tiny shorts that take every single individual question we've had, like what's a sleep dentist, or what is deep sleep, or what is healing sleep? And they are all my points of view based on my experience with my clients and patients.
So the YouTube channel, how do they find this YouTube channel? Does it say
Right
Right
Sleep
Sleep? It's Right Sleep also. Okay, good.
or Dr. Gominak. Yeah.
It's okay, perfect. The YouTube channel. I'll put that in the link to everybody. And if you're a clinician, I would assume they could go to the same site, and there's a section for clinicians for further training.
Exactly. I do give courses for this. We're right in the middle of one of the courses, and I'll be putting the dates for the courses. They're virtual courses. They're over 4 different separate meetings, and you can learn this more in depth to help add this to your practice as any kind of practitioner, dental, physical therapy, psychologist,
I mean, you've got
any
nurse
clinician.
practitioners, primary care doctors, you've got dentistry, you've got, I mean, I think, and what I love too is we talked earlier before hitting record, this is changing, and you need to be part of a community that is up on the changes and is, basically relevant. Okay. You don't want to just, D can be dangerous. You don't just start taking, everybody asks me that when I start as a clinician, I do order the blood work. I want them to go get the blood work, or I'll refer them to Ulta Lab or to have the blood work ordered. Um, just to at least say, where are you right now? And then how to best manage it from there. But everybody's like, is 5,000 enough? Should I take 5,000? I'm sure it's the same thing I get in sleep dentistry. What expander do you use on children? What's the best expander? It's like I don't know. I have to look at your child. What do they need? What's the diagnosis? We gotta. Am I looking for sagittal? Am I looking for transverse? Am I looking for both? Same with D. You can't just throw a hormone at somebody. You wouldn't just throw estrogen at somebody and say good luck. I mean, you got to be careful. This is like you said, we're biohacking here, people, and you really need to be in tune to yourself and your kids and your family, and you have to do this the right way. And I love your program, Stasha. You're brilliant. I'm honored to know you as a colleague, and even more so as a friend. And I thank you for being here today. I'll put all these links.
I feel the same way about you, Stacy.
Oh gosh, now you got me blushing. I'm serious. I'll put all these links in the podcast. I like to end the podcast on something, just kind of some, quirky questions at the end, just to learn a little bit more about you. So, with the holiday season approaching, Stasha, we've got Thanksgiving, Christmas, and all the other holidays kind of landing around December. What
Halloween. Don't forget
Halloween?
Halloween is
Oh
coming up.
shoot. Yeah, we got Halloween next week. What is your favorite? I want to say what's your favorite dessert, but if you're not a dessert person, or give me both, your favorite food and your favorite dessert at the holidays.
Turkey.
Ooh,
Absolutely. Turkey, roasted turkey with turkey gravy,
oh, that sounds
and
good.
then turkey sandwiches the next day with cranberry sauce. Oh my God.
Isn't it better the next day? I feel like
Yes.
turkey's so much better the next day.
Next day in a sandwich, it's remarkable. And it's not
Yes.
the same as those square turkeys that don't taste like anything, that taste like paper.
Yes.
And my favorite desserts are around Thanksgiving. And my mother-in-law made a chocolate pie that was amazing. And that's still one of I would have to say pie.
Mm,
I'm a cake person sometime, but most of the time around Thanksgiving, I would say pie.
I love pie too. I love pecan pie with a cup of coffee. That's like my favorite. That's sometimes a good breakfast for me after Thanksgiving in my pajamas.
I would say the same thing for pumpkin for myself. Pumpkin pie for
Ooh,
breakfast the day
yes.
after Thanksgiving. What? Wow, my mother-in-law and my husband make the best pumpkin pie.
Mm. Yeah, pumpkin. It's funny. Like it's got to be the spices have to be just right. The texture
Exactly.
has to be just right, or I'm
Yes.
like totally turned off. I'm a pecan girl, but if you make a good pumpkin pie, ooh, with coffee, all the spices, like, okay, I'm getting hungry. Okay, second question: Are you coffee or are you tea?
Coffee. I like tea also, but coffee would have to be what I do every day.
More so coffee. Teas are good in the evening. I mean, some
Yeah.
people do teas in the evening.
Decaffeinated tea in the evening.
Yeah, helps soothe. And then final question. I've never asked anybody this, but of course I'm going to ask you this. What is your favorite way to get vitamin D naturally?
Lying out in the sun. I
Like
mean,
at a beach? Like what's your
yeah. I mean,
favorite? Like I'm going to go get some vitamin
I
D.
love tropical places. So any place that's got palm trees and sand and water, I'm there. I love that.
Oh,
We
that's
just came
awesome.
back from Croatia, which had beautiful, beautiful views, but their beaches are really sharp rocks. So that was a
Ooh.
big bummer. And you basically have to climb down a rock to get in the water. So that was kind of a bummer, but it was a beautiful area. So any place that's tropical that has water and hot weather, that's my happiest place.
Hmm, I love that. Well, thank you for being here today. I feel like we're going to have a part two because I didn't get to like 90% of what I wanted to ask, because this is such a fascinating topic. It is such a needed topic. And I love all the research finally coming out. You have been, blowing this horn, and then I've been blowing this horn in my community of gut health, endocannabinoid system, connection with vitamin D health, all the bees. I mean, um, It's exciting. It's an exciting time, and I think people are going to start really listening to what you've been saying for years, Stasha. And your patients and your clients are lucky to have you. We're lucky to
Thank
have you.
you. Thank you.
Thank you, everybody. We'll see you next time.